So good morning, everyone, and welcome to the second day of Leprosy Research Initiative spring meeting. We have another jam-packed day in front of us with all sorts of good presentations. A number of people are still signing into the meeting as we're going along, and I'm checking over here at the chat, seeing the names of familiar names from a lot of people that I haven't seen for quite some period of time. So I encourage you all to make a hello as you come in and let others know that you're around as well. Today, for our presentation, our preliminary presentation, we have Dr. Yotsu, who is a dermatologist and associate professor at the Tulane School of Public Health and Tropical Medicine in New Orleans. She will talk to us about her interest in these regards, and I think you'll find it to be a very enjoyable presentation. Please, if you have any questions as we go along, enter them into the Q&A, and we'll have a few minutes at the end of the presentation to try to address those, and those that we don't get to, Reed can talk about or contact the individuals directly. So with that, I'll hand you over to Reed. Good morning. Thank you very much.
Thank you, Dr. Truman, for this invitation to talk at the spring meeting. And today, I'll be sharing with you some of the work that I did also with under the LRI funding, and some of the lessons learned throughout the process, which I hope they will be helpful for some of you currently implementing the projects. So this is the content of my talk today. And I also just saw the attendees list. So I think some of you know that I've been working closely with the WHO in development and also implementation of the skin NTD framework. But really, the start of my journey started in 2014 when I started to work with the local team in Côte d'Ivoire in implementing skin surveys. And from the very beginning, we did not only look for skin NTDs, including leprosy, but also other skin conditions. So that has been our approach all throughout the years. And there were gaps that there were limited dermatologists in country. Well, actually in Côte d'Ivoire, there are a little more dermatologists than other countries, neighboring countries. There are 80 to 90 nationwide currently. But then there are just huge disease burden of all kinds of skin conditions, including skin NTDs, which many of the conditions lead chronic clinical course. So just going one time or twice a year to certain places doing skin surveys was not enough. That just providing one-time diagnosis did not lead to good case management. And also many of the time that there was stigma and discrimination that the patients were feeling, that when the expert team, we were there, they will not come out to see us. It's often that when we leave, that the patients quietly go to the PHCs to seek for care. And then there was no capacity in the remote, these clinics to diagnose them and treat them. So with that, we started to think about developing some digital health tool that will help us in running a more longitudinal year-round surveillance system in place. And with the collaboration with the Japanese app company, we developed the eSkin Health app. And E means good in Japanese. So literally, eSkin Health means good skin health. So what does this eSkin Health app does is that it is a portable patient chart, which you can also use in offline condition, because as we all know that the internet is not so great in many of these places where skin NTDs are. and also when in need, that the local healthcare workers can be connected to a remote specialist. This was the LRI supported study, which ran from 2019 to 2022, which we implemented the project in Zonien, which is a district neighboring Liberia, so very remote from the capital city, Abidjan. It took more than 1 day, so 1.5 days to reach there. But the idea behind for choosing this place for this study was that it had many cases of leprosy. And there we ran this integrated approach with Skin Camp, including an eSkin health app, to have effective management of skin NTDs. This is the summary of the results, that we diagnosed a total of 3,000 plus cases of skin NTDs, but the place was also very endemic with scabies. And then the communities sometimes were 10% of the population were affected by scabies. So we saw this common endemicity of skin NTDs. Each of the activity consisted of around 1 week, which 2 days were used for training, and the remaining 3 days were for skin surveys. And like for one activity, average of 850 cases of skin diseases were diagnosed. We also were able to diagnose some of the skin NTDs that were unknown to exist in this region, for example, cutaneous leishmaniasis and mycetoma. But really, the challenge of using the digital health tool in this district was that the internet connectivity was very poor, which we did not really assess in the beginning of our project. And so it was very difficult to assess the impact of the eSkin Health app through this project, unfortunately. So we went on to implement the project in a more, in central of Cote d'Ivoire, where we know that we knew there were more access to internet, which was in Sanfra and Boafre. And this is an ongoing project until next year, funded by the NIH. And so shown on the slide is some of the studies that we've been doing. So it has been kind of the stepwise approach in the research methodologies that we've been implementing. That we first started with a 3-month trial, comparing the intervention, which used the eSkin Health app in the case management versus just the papers. But this did not go well. I mean, the outcome was very obvious. So currently we are, for the intervention, we are, so now currently for our study design, we are equipping the local healthcare workers all with the digital health tools. And currently what we are doing is this realist evaluation mixed method study comparing the urban settings and the rural, where the health systems are very different. But today I'm going to present some of the results from this 6-month study that we did, that we are almost close to publishing our results. And during this 6-month project, we compared the intervention period versus the period of the same months of the previous year. And what we saw was with the implementation of, with the use of the digital health tool, that we were able to increase 3 times in the number of skin NTDs diagnosed. You can see that for the baseline, there were more skin diseases reflecting the high prevalence of skin conditions in the communities. But with the eSkin Health app, because you need to enter, it's extra work. So the case numbers decreased but the diagnostic rate increased in the intervention arm. So this has been our kind of results for the quantitative part. And we also do surveys and also interviews. And these have been the strength of the program. And excuse me. And so some of the quotes are that the project enabled us to improve our consultations, and that they were able to give more precise diagnosis to their patients. It enabled us to get closer to the population who used to be very reluctant to come to us. Yes, our practices have changed for the better. To follow up patients, we don't have to go digging through the registers to find information about them. It's an opportunity for the public, because those who used to hide their illnesses now have the courage to bring them out in the open. We also ask users and patients what we can improve, but then it's more their suggestion or more things to do with access to care, which some of the things are out of the scope of our project, but which also reminds us that it is very important for us to communicate with the users or the patients to which extent we can provide to them in the very beginning, so we don't have these expectations. So skin NTDs should not be left behind of the emerging technologies. And what's next? Our newer studies are that since we collect a lot of data, including skin images, we are also working on how these data can be leveraged to develop further tools. And this is one of our pilot projects to develop a deep learning model for skin NTDs, and you can find a publication with the plus NTDs. But then what we found was that the AI was able to predict around 70% of the diagnosis, but there were a lot of variation between diseases. Leprosy was the most difficult because of the wide range of conditions. Also, that when you compare the images of the skin NTDs against the skin cancers, for example, in where the AI tool development has been made the most in dermatology, you can see that how heterogeneous the images of the skin NTDs are. So these all kind of things affect how the performance of the AI models will be in the end. So what we are currently doing is how we can remove these heterogeneous backgrounds and also trying to train the machine where to focus, where the skin lesions are. So we're also trying to do other things, but this is one of the things we have been doing, which is also published in this paper. So lessons learned. So we are, from the very beginning, we did not start with the technology, but with the people. And that we started with this cross-cutting kind of surveillance approach, which was not working, and understanding the real needs. And the eSkin Health app is very flexible, is that we adapt to, it is still actually, the development is in progress, because when we hear the needs from the users, we try as much as we can reflect them into the system. And you need to also be mindful of the local context, like the IT literacy, and also the internet connectivity. The images the size were big, and so we are still trying to work on this, how best we can upload the images at the earliest. Lesson 2 was that the infrastructure and the training, that we have this support group using the WhatsApp platform, that when the users have difficulties, they can send us a message to get support. Also, the training has been very effective, the way we provide the training. So how our program is taken by the users, really, I don't think it's not just that we are seeing the impact of our digital health tool. It's also this training that we provide to them, that we are taking this symptom to diagnosis approach, that it's not, we teach the disease first and then teach about the symptoms. We teach about the symptoms, and so they can have the differential diagnosis to reach the diagnosis. So this resonates with the nurses and the community healthcare workers, how they need to think when they see a patient. And this empowerment is leading to the uptake of our approach. Lesson 3 is that data reporting and publications are very important. And the eSkin Health App collects data, so we can export the data into Excel sheets easily to analyze data. That has been really the strength. And I mentioned that eSkin Health App is flexible, is that it can also adapt to different projects. And so we have been working with other projects using this system. Sometimes publications is not easy, but it becomes your, like for this, I'm showing this one example that I showed this image earlier, which was a cutaneous leishmaniasis case in ozonian, which took us 4 or 5 rejections after being able to publish this, but we persevered. Why we got the rejections from journals or that we did not have the PCR results. But it was just so difficult for us to have the results because the patient was in very remote place, and also he unfortunately passed away before we went there again to collect the samples. So there was no way we were able to get the PCR, but that was the rejection that we got. But it was important for us to publish this case because there have been very few cases of cutaneous leishmaniasis reported from Cote d'Ivoire when it is mentioned as an endemic country by WHO. So it was important for us to do this. So perseverance is important, and it becomes your voice, your evidence, and your leverage. And country ownership is crucial in the end to be sustainable, which is our hope. And we've been engaging the national and local stakeholders from earlier on of our project. And initially, when we were starting the teledermatology, we were also thinking of involving the international dermatologists. But in the end, we are only having the Ivorian dermatologists in the project and having their leadership, which we believe will support the sustainability of our integrated surveillance approach plus in country. So the vision is that with the use of such technologies, that we can provide the care where patients and the families reside, improving their quality of life, which is the vision also outlined in the Skin NTD framework. So with that, I would like to end my talk, but I cannot thank all the people involved in this project. It has been a huge number of participants, and we could not have done with the support of the National Control Program from Bloody Ulcer, Leprosy, and also all the dermatologists and the NGO Hope Commission International Cote d'Ivoire. And I would like to extend our thanks to all the patients, families, and the communities. So that's all from me. Thank you.
Thank you very much. That was a nice presentation. There's no questions in the Q&A just yet, but I think that probably some will come in as we move forward. One of the things I wanted to ask actually is how much time does it take for the dermatologist to interact on these inquiries that you receive through the skin app type of thing? And within that is that I'm also curious about what is the degree of negative diagnoses or non-diagnoses returned with all the inquiries that you might run across?
Yeah, thank you for those questions. So when we started the project, from the time of the registration to the time of the dermatology diagnosis was around 20 days.
Okay.
So when you hear that, some people might think, oh, it takes 21 days. It sounds maybe too long. But then when I asked what they thought to the local users, they were actually happy that even 21 days, they did not even get this support earlier. So it's a lot better than no diagnosis. But still, it's long. So we are trying to improve this. So at all time currently with the project I introduced under the NIH, the Mind the Skin, we are currently to 10 days. But that is also because we are now having more dermatologists diagnosing cases. And so there are several elements, factors that feeds into how fast we can provide the feedback. And for the second point on the negative diagnosis or some of the cases we cannot diagnose, yes, they are there because, for example, like subcutaneous lesions, we cannot diagnose those things. So for those, but even that some of the conditions are difficult to diagnose without doing skin biopsies, even you're seeing a patient face to face. So that also needs to be considered. But then another thing is that, yeah, some of the cases lacks in data for, like, example, itchiness, pain, which are, we do have that information to be collected. But sometimes it's still difficult to diagnose. And then in those cases, we have this choice in our diagnosis that indeterminate diagnosis, we cannot diagnose even we see the case. So that is one of the analysis that we are doing, what kind of cases are difficult to diagnose by teledermatology.
Also, we have a question from Nora Cardona, who's asking if you could explain briefly how you use AI in the project.
Yes, thank you for that question, because I'm thinking sometimes when I talk about AI, I'm making people confused that we are using AI currently. But this is another project that new project that we want to do. So the eSkin Health app itself is nothing to do with AI currently. And I think every digital health tool has its own functions, and eSkin Health app should remain as a portable patient chart that facilitates teledermatology.
And
the AI portion, we are trying to develop some algorithm and that, but that will be another app if we are going to develop an app.
And Kadis Babosha asks, well, first, she thanks you for sharing this great work. And she asked that once diagnosed, were there issues in patient management, like the lack of medication and so forth as that? And I also wondered if there's an educational component for patients through the skin app type process. But specifically to Kadis' question was about issues in patient management.
Yeah, so that was also what we hear from the community, that, oh, why we are not providing drugs. But to provide diagnosis, which is critical to lead to appropriate treatment. So this message is very important to make people understand. So yes, we need to have a good strategy to do that, which we are still working on. In terms of patient education, the app has this automatic function to organize all the photos. And so just by at a glance, you can see how the patient came to the clinic in the very beginning to where they are at when they're at the clinic, the follow-up. So if they know that they are getting better through the images, that will help them to adhere to the treatment. And then if the users, the nurses, see that the patients are getting worse, that helps them also to make a decision that they need to be referred. So the images has been a very strong tool in the project.
Right, and that will take us probably to our final question here, and it sort of tacks onto that. Is that if you could just briefly describe the methodology from the beginning of the suspicion in the field to the diagnosis. And this is from Maria de Jesus de Alcancar.
Okay, thank you for that question. Sorry, I did not include a clear diagram for that. But so data flow of the patient is when you first register the patient information. This can be done offline. And then when the users have the access to the internet, they can upload the data to the server. And at that point, the remote dermatologist can review the data and make the diagnosis. So I mentioned about the delay in diagnosis, the time from registration to dermatology diagnosis. There are several factors counted in. Is that also it depends on when the data is sent to the server. That is also there. So in the beginning, we had some difficulties in uploading the images to the server. That also delayed our diagnosis. So that is the data flow.
All right, well, thank you very much, and thank you for your presentation today. We really appreciate it. I also appreciate seeing views of New Orleans and Tulane again, which I miss from time to time. With that, we'll just go ahead and prepare to move on to our parallel sessions. We'll leave this standard session, and we'll invite everybody to please log on to your track A, track B, and enjoy the ease at which one can switch between tracks with this setup that we have here. So thank you for joining us this morning, and we'll see you around the rest of the session. Thank you, Ree.
Thank you for the invite again.